Okay, thank you. Don't think I'm quite the president of the Medical Association, but those are my main comments and disclosures related to this presentation. But I did write the STEMI section for the most recent Australian guidelines. Although it was a committee document, I was the lead writer. So what I'd like to briefly talk to you in the next 12 minutes is just go over a Cook's tour of the key things of what I think is important for cardiogenic shock complicating STEMI. So a few background definitions and rates. Prevention was important, and I'll talk a little bit about that. Medical therapies, I was asked to talk at the AHA about this 2 decades ago, and there was a whole range of drugs and other things like systemic cooling, etc. None of them have turned out to be useful and have found a therapeutic role, so I'm not going to go over that. I'm going to talk a little bit about IABP, revascularization, and impeller. Now, because ECMO, I'm not sure how many of you do ECMO. With us, we are putting in the line sometimes, but it's a multidisciplinary approach, so I don't think our time will permit us significant discussion about that. So what are we talking about? Systemic hypoperfusion manifest with cool periphery, clammy, altered mental state, raised lactic acid level, pulmonary congestion, and a systemic blood pressure of less than 90 for at least 30 minutes in the face of correction of any heart rate or volume issues. And predominantly it's due to LV failure. About 15 or 20% are due to mechanical causes, and it's always important to identify those. I've spoken about that previously at major meetings. 30% are due to free wall rupture, but examples of all 3 are shown in this cartoon. I'm not going to talk further about that. Now, over the years, and this is a relatively old registry showing numbers, but the mortality rate in unselected patients tends to remain around 50%. Prior to the shock trial, which I'm going to talk a little bit to you about as I was an investigator, it was nearer 80%, but we've hit a bit of should we say, a glass floor about that, although we can speculate at the end about how things may improve. There was a recent Sky document, the details of which are shown there at CCI in 2019, identifying the various stages. And, you know, it's important, especially stages A and B, to try to work out who might be at risk. Someone with a large anterior infarct, someone with prior infarct, someone with prior infarct and a background of controlled heart failure. And someone who's either got relative hypotension or tachycardia without at the time hypoperfusion. And so those are important to identify. Now, in terms of prevention, and one of the previous speakers speak about, and one of my areas of interest is pharmacoinvasive PCI, but one of the advantages of an upfront lytic strategy of timely primary PCI isn't feasible, as can be shown in this meta-analysis, is that early lytic therapy prior to PCI can reduce the rate of cardiogenic shock quite significantly. Here the hazard ratio is 0.63, highly statistically significant, and although in this meta-analysis there wasn't a mortality benefit, because the large proportion of deaths after STEMI are in fact due to cardiogenic shock, you would expect in a more powered trial that that there would be a mortality difference. There's been various randomized trials with various interventions, and I might just talk a little bit about the shock trial because this is only a short presentation, and also talk a little about IABP shock. Now, this shows the numbers of patients recruited to the major trials, and probably the biggest, most recent one is culprit shock. This previous speaker spoke about that, and I'll just comment while talking on this main slide that culprit shock tended to suggest that we switch from the strategy adopted back in the shock trial in the 1990s for complete revascularization to culprit-only revasc in the setting of shock. So, in fact, unfortunately, as it was designed with 30-day mortality, shock was in fact a negative trial in a purely academic sense, because 6 and 12-month mortality weren't the primary endpoint, but you can see that there were significant differences in outcome. What was done? Well, these are some of the adjunctive therapies given. There was a reasonable amount of lytics given, lytics and balloon pump. Balloon pump was recommended. Similar rates occurred of right heart cath and ventilation or assisted breathing. Rates of angiography is shown there. Immediate intensive medical stabilization as IMS, and ERV is emergency revascularization. And you can see that there was a 62% absolute difference in that. And interestingly, the PCI and CABG, this number adds up a bit bigger than 87%, and some had a bridge from one to the other. And I'll give you an example if we have time right at the end of a case I had where I think it works. So these are the potential devices that we can use: balloon pumps, impeller, and how that works. Tandem heart, which I'm not really going to talk about, and VA ECMO I've mentioned, but that almost involves a symposium in its own, and really is something that requires a team approach, including the cardiothoracic and cardiovascular surgeons at the institution. Now, you might have thought that a decade ago, following this present paper of Holger Thiel in the New England Journal, which effectively showed that IABP routinely wasn't useful, that we should, shall we say, throw it out. But I've kind of always argued that that may be perhaps throwing the baby out with the bathwater. Then there are various issues about the trial. There was some crossover. The mortality was lower than expected at 40%. Some of those randomized to IABP didn't actually get it. They were a relatively unsick population, as 86% didn't require support during PCI anyway. Some of them had non-STEMI prior CPR, so it was a bit of a heterogeneous group rather than just, for example, high-risk anterior stenting, which I'm going to talk, and the anecdotal thing potentially in some patients. The next, the paper, which was work involved, that I was involved with from the shock trial and registry, perhaps gives some insights as to why it may work in some patients. And what we looked at, and I'm just showing you the registry data here from this the trial data, but all of the data is in the publication if you want to look it up. But if this subgroup of patients, which was about 60% of enrollees, mortality was shown by, with respect to whether you got complete reversal of systemic hypoperfusion or not. And in the group who did, the mortality was up around 40% or 60% survival. But in the others, there was a major mortality was higher than 70% and about over 30% absolute difference in mortality. So there are clearly some patients, probably a subgroup, who respond well to the balloon and that or IABP, and that's probably all you need for those patients. The problem is that we're still not good enough at picking who, which, and why. I've talked a little bit about ECMO. Now, this is the design of the impeller device. It requires 14 French peripheral cannulation. So it's not something that people should undertake unless they're got significant experience with large bore peripheral cannulae. Now, these are some of the trials in cardiogenic shock, as I've shown, sort of or not yet reported. For example, this ECTS trial, and that's partly why I haven't talked about it. Euroshock is ongoing and Danger is ongoing. They will give us some insights into further what we should do. So I've been almost 12 minutes. So what should we do, or what do I think in 2022? I think we should aim to prevent shock by early. We heard issues of, in my view, those certainly even in Australia are perhaps the rule rather than the exception. So I think often if someone doesn't have contraindications, they should have lytics if they go to a non-PCI centre. The issue of how and which mechanical support we use is often challenging. I think if a person comes early, they're a bit hypotensive, and you think they may get a good response, or you put in the balloon and pump early and they respond promptly, then that's probably okay. If they don't respond, bat on, and I would escalate then to impeller. And I think we need to await upcoming trials. And I'll give an example. This is a patient, he was a former captain in the South Vietnamese Army, was out dancing with his wife at about 9 o'clock on a Sunday night. Ambulance called and said 30 minutes of chest pain. I live 10 minutes away from the ambulance. We called back the ambulance officer. You can see there's a mobile number there in the car. When I got this ECG transmission, there's widespread early anterior infarction with reciprocal changes. And so I thought this guy's likely to develop shock. His blood pressure was already 70 systolic. I went to
Dr.
the
Franz, you have to...
registrar happened to be there. I said, intubate the man. They didn't. And by the time I came back dealing with another patient 10 minutes later...
You have 2 minutes to finish, Dr. Franz.
This is the angiogram. So his right coronary showed a tight stenosis. He had a blocked LAD there, which we opened up. You can't see it very well in this picture, but he has a 70% left main. We just gave him Tyrofiban balloon pump and he went to surgery. Thanks for your attention.